inadvertently. I think what I'm going to do is cut the drugs of abuse lecture because I sort of go crazy on that one. It's like 70 slides. And I talk a lot about drug trafficking and stuff like that that's not relevant. So I'm going to do a recorded one because I like it. It's personally something I'm really interested in. So if you guys want, you'll have access to my wealth of illegal drug knowledge if you want that. If you work in an emergency department in Minneapolis for a long enough time, no, it's always been something like addiction medicine, stuff like that's always been very interesting to me. Why, I have no idea, but I like mental health as well. So this is one of my favorite topics of the year. And I wanted to be a mental health pharmacist for a long time, and there just wasn't any jobs available, so I chose different career paths. But anyway, here we are. I still keep an interest in it. We'll start with depression and then move on to antipsychotics later today. So depression is a really common illness. You're going to encounter it in any aspect you practice in. I think it's really important to look at mental health in the context of any environment. So I think a lot of people are like, oh, mental health meds, you look at a patient and you're treating their diabetes or their heart failure or whatever, and yes, they're on some antidepressant, I don't really care. That's the wrong mindset to have, I think. I think we should be treating mental health as a separate thing, yes, but also integrating it into the rest of how we treat people holistically. So I'm a big proponent of educating in mental health and understanding how patients take mental health medications, how they can help them, and how we can modify those medications to make them work best for patients. Sometimes people come in to like a med surge floor for something totally unrelated to their mental health, and you look at their mental health meds and it's a total train wreck, and you're like, who put this person on all these weird meds? There's duplications, there's dosing issues, this person's elderly, and all these things are anticholinergic. So I think it's very important for us to take a good look at these meds and have a good understanding of them. So anyway, antidepressants, about 26 available on the market right now. 1/3 of patients will experience remission after one single round of treatment. So that shows you that it does take a few trials to get it right, which is really frustrating for both patients and provider alike. Subsequent rounds, studies have shown get about 20 to 25% more, and that could be adding a second medication or it could be switching a medication as well. And 30% of patients with depression will have some form of relapse throughout the treatment of their disease. Complex disease with multiple factors to consider. So there's a lot of drugs that we use for depression that work very similarly. So a lot of them work on serotonin. We'll talk about that in a little bit. But the point in this bullet point is that we have a theory for why people get depressed, and we know drugs work that, for example, increase the amount of serotonin available in the specific synapses within the central nervous system, but we don't know. Beyond that, it gets a little bit complicated. And so while we know that there's a serotonin role, it's likely much more sophisticated than that. And we aren't really sure exactly how to pinpoint what exactly causes depression or how the best way is to treat it. There's multiple ongoing studies and there's combination therapy. So you're looking at different tiers. So we're going to talk about pharmacology today, and I'm going to mention things like psychotherapy as well, but that's certainly important, and there's lots of good data out there that says that combination psychotherapy plus pharmacotherapy is going to be better than either one by themselves. Not a quick fix. Treating depression, most of our medications are going to take at least 2 to 6 weeks to kick in, which is, again, another frustration, so especially when you're looking at significant relapse in a majority of your patients, or not relapse, sorry, significant ineffective treatment, I should say. Initially, for a lot of your patients, it's going to take months to get people on the right doses. I've talked to people who they said they've taken 5 to 10 years to get the right combination of medications. Now that's maybe a little more complicated with some bipolar involvement and things like that, but still, mental health in general can be really challenging to get the right cocktail, if you want to say it that way, of drugs. Yeah.
How long does it take for the side effects to kick in?
Side effects can kick in a lot faster. It depends what side effects too. A lot of antidepressants might be slightly anticholinergic, so initially you might get dry mouth, things like that, but over time you should get maybe a little more used to those. Some of them cause GI issues too, but yeah, that's probably going to happen fairly quickly for a lot of patients. But
so patients kind of tend to quit them before they experience.
Exactly, that's a great point. Yes, so that happens quite often too, and so there's been a lot of research into how can we bridge people to an effective antidepressant dose and somehow mitigate the side effects, and it's one of the few diseases out there that we really don't have a good response for that. There's no bridge to antidepressant effectiveness. There's been some trials, interestingly enough. I have this bullet point here on ketamine. I'm not even presenting, am I? There we go. Ketamine. Talked about this on and off here a little bit, but they did some trials looking at giving people doses of IV ketamine, which is generally used as a sedative. It's used for analgesia now for various indications, but historically it's been used as a sedative for anesthesia. And they've been giving people low doses of ketamine IV through various protocols that researchers have developed that I'm not going to go into. But what they found that sometimes you can actually get people out of a depressive cycle with ketamine, but it doesn't last. So the idea is maybe in the future we might have inpatient protocols where people get admitted to the hospital if they're severely suicidal. And that happens already, right? It just takes them a longer time to get out of the hospital. This might accelerate that process if we can get some more drugs on board that can help bridge us. Because we know that these serotonin medications actually do work pretty well in a lot of patients. It does take some trial and error here and there, but ultimately they do help in a fair number of patients. So how do we get that process a little more streamlined? So anyway, I think that's where the future is going. We aren't quite there yet, but there's some interesting work being done. So if you work in mental health, or if you want to go into mental health, keep ketamine in mind as something, especially if you work in acute mental health or more high acuity levels. Yeah.
What does your statement subsequent rounds make it 20 to 25% more?
Oh, that's like 25 to 20% more. Sorry, I should probably word that better. So less remission, I would say. So basically, if you say like one third of your patients will experience remission after one round of the treatment, that would mean that after a second round of treatment, you're going to add about 20 to 25% more. So after 2 rounds of treatment, again, whether that's changing a medication or adding another medication on, you're going to be at about 50% or a little higher than that of patients successfully treated. So in remission from depression. And then you're still at risk for about 30% will have a relapse at some point, even if they go into remission from their disease.
So you're getting more remission.
More remission with subsequent trials, yes. But it's diminishing returns. Oh, social stigma. I shouldn't just blow past that. So huge social stigma around mental health and mental illness. Even just the language people use to describe psychiatric behavior and things like that. So I'm guilty of this too. I think I've worked in an ER long enough where we just refer to mental health people who come in, and the system is so backed up right now that what happens is people come into an emergency department with a psych emergency. They sit in the ER for days sometimes because there's no beds for them, and legally you can't discharge somebody to another facility unless you have an actual mental health bed for them to go to. So sometimes we even end up with people staying at like our West Health ER, which doesn't have a hospital even attached to it in Plymouth. And they just sit there because legally we can't even move them to Abbott's ER. So it's interesting and complicated. But the point is that we call them boarders, and it's like, I've got 4 boarders this morning. And as a pharmacist, I come in and I do their medication reconciliation. I kind of get carte blanche to order whatever I think is necessary for them while they're staying with us. The ED providers don't really want to touch them because that's not really what they trained for. And so we get in these interesting situations where you have to work with these patients and help them best you can. So I think it's always good to keep a good attitude about it. And again, there's language and stuff about mental health patients out there that gets, I think, discouraging from time to time. But I would say try and keep a good attitude and try and remember these patients are struggling with a disease just like anybody else we're trying to treat and help. All right, so what is depression? Well, unipolar major depression is the term for standard depression. It used to be called major depressive disorder, but this is the more modern way to say it. Somebody who has suffered at least one major depressive episode and has no history of mania or hypomania. That's a big component to diagnosing depression. If you have any history of mania, that puts you in the bipolar category, and you're treated differently. If you treat somebody who is bipolar for just depression, your chances of inducing a manic phase are quite high. And actually, that's how some people's bipolar get diagnosed. We're going to talk about that more with bipolar. But some people like their manic phases, so they might not go to the doctor while they're manic. And they might be functioning pretty well in society when they're manic, if they're kind of on the low end of the spectrum. So you end up treating them for depression, and they end up getting manic more often and more often. And ultimately, they might go into full-out stage of mania where somebody finally admits them to the hospital, family members get concerned or something like that. There's some other criteria here as well that kind of the hallmark symptoms of depression: depressed moods, anhedonia, sleep disturbances, eating disturbances, other things like that. This is some old data, but a map about depressive adults meeting criteria for current depression, and this is 2006, 2008. So go upper Midwest, I guess, and I don't know. You'd think people who live in cold climates like Montana, North Dakota would be sad because they don't see the sun all that much, but I guess we're doing pretty well. And Minnesota always makes the list for healthiest states, so maybe that has something to do with it. I don't know about Wisconsin though, how they got in there. All right. Demographics. So age, most prevalent, usually gets depression usually gets diagnosed later in life. For most people, doesn't mean it's more common necessarily. I think it's common across a lot of different age groups, but where you see actual diagnosis usually happens a little bit later in life. Ethnicity, pretty similar across most different ethnicities, not a huge difference there. Women tend to have slightly higher rates than men, but and then twice as likely to have depression and symptoms of depression as men of the same age, interestingly enough. 1 in 10 women experiences symptoms of depression after having a baby. We'll talk about postpartum depression this summer a little bit. One thing to think about with depression is indirect costs. So there are direct costs to depression, right? You manage it with medications. You go to the psychiatrist. You might get admitted to a hospital potentially if you have severe suicidal ideation or behavior. But just the idea that you aren't as functional at your job is something interesting that's difficult to quantify, but some studies have done it and show that actually depression has hidden costs behind it. So even if somebody is treated and is working and is going to their job and showing up every day, they might be just not as productive as they could be otherwise. So you're probably losing some sort of productivity, which translates ultimately to lost revenue at some point. All right, so our goals. Symptom remission. This will not be completely possible for every patient. It's possible for a lot of people, and it's definitely a worthy goal, but some people it might be very difficult to rid them of all depressive symptoms. Restore our basic functioning. So we want them to be able to take care of their family, go to their job, go to school, whatever it may be. Prevent comorbidities, death by suicide being the major thing we're trying to work to prevent here. General health problems as well and substance abuse are things that can occur just based on, sometimes you could chalk it up to a coping mechanism, other times it might just be something that existed prior to the depression or possibly contributed to the depressive state the patient's in. May require patience, both the patient and the provider, we talked about that, and multiple drugs is not uncommon. Okay, here's my depression joke. This stormtrooper, he probably got fired after he let them through. All right, Star Wars joke. And then my cat joke here. Catnip no longer dulls the pain. It's a really sad looking cat, huh? All right. Serotonin reuptake inhibitors, or selective serotonin reuptake inhibitors, SSRIs, drugs that I don't know how many millions of people are on them worldwide. I would venture to say tens, maybe 50, 100 million people, who knows, maybe a lot more than that. First line for major depression, general anxiety disorder, and obsessive compulsive disorder. I'm not going to talk a lot about OCD and other things because they're basically treated a lot like depression. We're going to talk a little bit about anxiolytic medications that work different from our antidepressants. But ultimately, if somebody has general anxiety, we treat them pretty much the same as we would major depression, same drugs. So even though the diseases manifest quite differently, they are all treated essentially the same way. Some of the drugs have more data in certain populations than others, but SSRIs are for the most part SSRIs, and they should work pretty much unilaterally across the different medications. Generally speaking, SSRIs are a fairly well-tolerated group of medications. They are minimally toxic in overdose, which is a huge advantage to their predecessors, which were terribly toxic in overdose. So if you took them, like a tricyclic antidepressant, there's not really a good thing you can do for a TCA overdose. It's pretty much a death sentence if you absorbed it. You can try some tricks, but there's no reversal agent, and it's cardiotoxic. SSRIs are not. You can take a ton of an SSRI. You might get sleepy or sick, but you might get some QTC prolongation in rare case reports, but for the most part, they're very well tolerated, even if you take a ton of them. So that's a nice advantage when you're dealing with patients who might be suicidal. Previously, with some of the more toxic medications, you'd have to really be strict about how you prescribe them, 1 week supply at a time, never giving them enough that they could lethally overdose themselves on. We don't really have to worry about that with SSRIs. You may switch between agents without retitrating the dose, without needing to cross-taper. So I'm going to talk about cross-tapering a little bit with antipsychotics. Cross-taper just means like we talked about a little bit with anti-epileptic drugs, starting one and decreasing one at the same time. So you're dropping the dose of one while you increase the dose of the other. With these drugs, they're thought to be similar enough where you don't actually have to do that. Well, that's a nice advantage. So basically, if you're like, well, this person's on this SSRI, it's working okay, I want to switch them to another one because I think I've had better experience with this, or maybe they have a sister who's on a different SSRI and it's working great for them. A lot of times that's a cue. If you have a family member who's having success with a certain antidepressant, try it with the other family member. A lot of times psychiatrists will go that route. But anyway, so if you want to switch somebody to a different drug, you can just use a dose equivalent chart, basically, or kind of guesstimate a little bit. And you don't have to spend a whole 6 weeks titrating them up to the effective dose you want to hit them at. Very helpful for people on high doses of SSRIs if you want to switch them. Patients may respond well to one and poorly to another. That goes for both efficacy and safety, so side effect profile as well. Blockade of serotonin reuptake by fluoxetine. This drawing shows you essentially how SSRIs work in a nice cartoon. So what you have is one neuron releasing serotonin and communicating with the other neuron, and you have reuptake channels here, so this pink thing marked here. So normally you release some serotonin, some gets used, some gets reuptake, there's some floating in the synapse at any given time. The theory behind depression, or one of the theories, is that people who have depression don't have as much either of production of serotonin, or they don't have as many receptors to use it. What it is I don't know if that's possible to understand fully. That's the theory, and that's how these drugs work. So we know these molecules interact with the reuptake channels here. So here's Prozac, or fluoxetine, coming in and blocking this, and what happens is over time you get increases in serotonin in the synapse, which ultimately allows you to utilize these receptors to their full potential. The other thing to think about too, and one of the reasons and theories behind why they think it takes weeks for these drugs to kick in fully, is because over time your body will actually start making new serotonin receptors. So you might see some new serotonin receptors on the side. Therefore, you can actually use more of the serotonin that you're now used to. And your body, it takes a while to upregulate receptor production. You have to build the new proteins and all that stuff. So doing that takes weeks, is what the theory is. So that's part of the reason why I think antidepressants take a while to work. Not a firm theory, but it's one I've heard and one I like, so I'm going to go with it. Oops, I just skipped to the end slide. Sorry, let me go back here. Okay, class-related side effects. Now, side effects will vary SSRI to SSRI. Some of them are pretty common throughout the class. GI, and I put some of the more common ones here. GI diarrhea can happen with anyone. It's really common with sertraline or Zoloft. Probably one of the biggest downfalls to that drug and why people might stop taking it. Sexual dysfunction or decreased libido is pretty much across the board with every SSRI. There's some mitigation strategies we have for that and some other antidepressants that don't have that aren't SSRIs, but essentially every SSRI will cause this. And it's going to happen to men or women. Some people might not have any issue with it whatsoever. Others will have detrimental problems with it and be like, I can't function sexually, you have to do something about this. And that's a big concern for a lot of people. So it's definitely something to keep in the back of your head. That's probably one of the biggest ones to remember for patient satisfaction purposes and patient adherence, that it's something to counsel somebody on and know that there are options and alternatives, and we'll talk about some of those towards the end of the lecture. Somnolence, usually not sedating, maybe slightly. Weight gain, likely not going to happen, but sometimes if you have somebody who hasn't been eating very well while they're depressed, they might start eating again once the symptoms improve, and that can just be a weight gain cause. So it's more of a correlation versus actually a causation. Bleeding may inhibit platelet aggregation. So if you prescribe antidepressants, you'll get flags if people are on aspirin or warfarin or I don't know, NSAIDs sometimes even. It'll say increased bleeding risk. It's not a huge clinical significant thing. It's not contraindicated. At this point, I kind of just ignore them, to be honest, when I see those flags. It's a minor drug interaction that can possibly cause increased platelet aggregation inhibition. And I'll talk about a couple that are more anticholinergic. Generally speaking, they aren't terribly anticholinergic medications, but some are more so than others. All right, so citalopram and S-citalopram are Celexa and Lexapro. Celexa or citalopram used to be the go-to SSRI It was one of the best tolerated ones on the market. And now Lexapro has kind of taken it over. Both are generic now. So S-citalopram is just the S-enantiomer. And they're essentially, so this isn't where I'm trying to trick you like the carbamazepine question, if you thought that was a trick. This is actually pretty much the same drug. So there's not a whole lot difference here. The one big thing, though, to remember is that Celexa or citalopram has much more significant QTc warnings on it. In fact, the FDA has slapped a whole bunch of warnings saying, don't give more than 40 milligrams to your patients. If your patient's over 60, don't give more than 20 milligrams, which is a really low dose. People previously were taking 40, 60, sometimes even 80 milligrams of citalopram. And so all of a sudden, all these clinicians were in a rock and a hard place. You're like, okay, I have a patient who's 68 and he's on 60 of citalopram and he's doing great. QTC is fine. What do I do? Well, generally speaking, just leave it alone. There's no real reason to get bent out of shape over this. In fact, I've read a lot of studies that looked at overdoses from citalopram, and there's rarely any cardiotoxicity that's reported. There's been a couple case reports here and there of it, but really where I'd get concerned is if you have other QTC prolonging medications on board as well. Otherwise, I don't get too worried about this one. If you're starting somebody on citalopram and you're worried about it, you could always do a baseline EKG, see what the QTC is. But other than that, that's probably the biggest downfall. Citalopram does not have the same warnings on it. Now, it's probably thought to cause QTC prolongation as well, but it just doesn't have the same evidence or studies behind it to support that it's a risk, and it doesn't have the same FDA warnings behind it. So that's the really big difference between the two. Otherwise, they're both generic. And again, citalopram was really widely used, but now S-citalopram is generally the go-to for a number of people. It's pretty much first line for most things. Our pediatric psychiatrists use it a ton in kids at lower doses, but it's one of their go-tos for pediatric depression. And I think if our peds people are doing that, it's probably one of the safer ones that has evidence for lower toxicity overall. Shoot, I did it again. Keyboard's all messed up. All right. Okay. So I gave these two their own slides. Not like they're that much more prevalent than the other ones. These are all really common drugs. I should preface it by saying that. The other ones, I don't have much to say because this general side effects slide basically covers the toxicity. They're all pretty effective medications. There's been a lot of studies that look at as one better than the other, and really they aren't. They aren't really. One's not more successful at treating depressive symptoms than another. Sertraline, we talked about the GI side effects, so diarrhea with that one. Some drug-drug interactions here. Fluoxetine or Prozac, one of the things to know about this one, it's got a 3 to 4 day half-life. So if you have a patient who tends to miss a dose here or there, this is a great drug for them because it doesn't really matter. It's going to take several days worth of missed fluoxetine doses. And I've had patients who say that they tapered off fluoxetine and stopped, and they still felt like they were experiencing antidepressive effects or the side effects from it for months afterwards. So it can take a long time once it builds up in your system to fully get out. This was one of the first drugs actually approved in children, and it had the lowest age FDA approval for quite a while. So it's one of the best studied ones in kids. Not to say it's the best. Some people don't like it just because it lasts such a long time, and they're concerned about it accumulating over a lifetime of use potentially. But there's not really any safety data to say that that's a problem either. So I don't know. Paroxetine is Paxil. Paxil it's one of the older ones. It's one brand name a lot of people know pretty well. It's the most anticholinergic, and it's probably my least favorite just because of that reason. I see elderly people on this sometimes, and I just like, why would you pick Paxil? It's very strongly anticholinergic. The rest of them aren't really. Pick something else. That's all I have to say about Paxil and elderly. Otherwise, it does work. It's fine to use. It does have a short half-life though, so it's kind of the opposite effect of fluoxetine. If somebody runs out of their fluoxetine or stops at cold turkey, they probably aren't going to have any what we call discontinuation syndrome, which is the nice way of saying withdrawing from an SSRI. And I'll talk about that in a second here. But it's got a short half-life, and so people who stop this cold turkey are going to experience it leaving their system a lot faster than somebody like on fluoxetine. So they can experience that discontinuation syndrome more abruptly and more suddenly, and it's usually more profound. Paxil is also fairly sedating, and it's a strong 2D6 inhibitor, excuse me. I didn't get that on the recording, did I? I think so. So drug interaction. So again, Paxil, effective, fine to use, not my favorite. If you prescribed it to a relative, I'd tell you to pick something else. All right, SSRIs, vilazodone or Viibryd is a new agent. It's not generic, so it's expensive. It's activating, meaning it, I guess the opposite of sedating, right? So it's not necessarily like a stimulant, but it does tend to cause some sleep disturbances in patients. GI effects, diarrhea and nausea are common with this one too. Why am I mentioning it? It's new. People like new psych meds because you have these groups of people who nothing works for. So all of a sudden a new drug comes on the market, you're like, oh, let's give it to them and see if it works. And so we do see a fair amount of these new drugs actually getting pretty good game time at my hospital anyway. We have a pretty high acuity psych patient population at Abbott. So I do see a lot of these new ones used quite a bit. But when psych drugs come, you have patients who have tried a lot of different combinations. So when there's something new in the market, people tend to jump on it. Fluvoxamine or Luvox is a really old SSRI that you might see only in really desperate salvage situations. So I'm not going to ask test questions on fluvoxamine. It's just up here. It's like Paxil, but worse. It's very sedating, lots of anticholinergic effects, terrible drug interactions. It's really old, probably the original SSRI out there. And again, I only see this on people who it's kind of like a salvage therapy. They've tried a lot of other things. Some people think fluvoxamine might be more effective than some of the other ones, or more potent, which might be true because it's got such a nasty side effect profile. So who knows? Okay, black box warning, then I'll talk about discontinuation syndrome a little bit. Black box warning is on every antidepressant, and they say that they have the increased risk of suicidal thinking and behavior in children, adolescents, young adults 18 to 24 years of age with major depressive disorder and other psychiatric disorders. Consider risk prior to prescribing. So do you care about this? I don't know. Generally speaking, no. We're still going to treat these people in this age group like we would anybody else. We're not going to withhold treatment from them if they're depressed. However, the thought is that for some reason when you take an SSRI, one of the first effects you get from increased serotonin might be some rebound energy and motivation before the actual full antidepressant effects kick in. So the theory is that you have these young people who might be more suicidal potentially or more impulsive than other age groups. And so all of a sudden they get motivated, they're still kind of depressed, so they actually attempt suicide at higher rates than their peers. Short-term studies did not show an increased risk in patients over 24 years and actually showed a decreased risk in suicide in those over 65 years. So it does seem to change with age. This isn't something that happens a lot. It's not like every 18 to 24-year-old is out there, oh, I just took my Prozac for the first time, I'm going to go off myself. It's rare, but it is a trend that the FDA noticed. And black box warnings have their own faults with them, so I'm not going to go into that. But it is something to consider, but just keep in the back of your mind. I would say if you're going to start an SSRI on a younger person, just make sure they have a good safety net and a plan in place and that they're probably undergoing some psychotherapy regularly at the same time. All right, discontinuation syndrome. So what is this? They call it this specifically for the antidepressants as a group, mostly SSRIs related, some SNRIs, which we'll talk about here in a second. But basically, if you abruptly stop your SSRI, you can get some GI side effects, some sleep disturbances. But what I like to think about it is it's sort of just rebound of whatever you were trying to treat. So if you're trying to treat depression, you're going to feel maybe pretty crummy. A lot of people get irritable, anxious, even if they didn't necessarily have borderline underlying anxiety to begin with. Those are probably the most common things that you're going to see. It's not life-threatening, like you're going to have a seizure or something like that. But it can definitely affect the central nervous system from a lot of different parameters, as you can see based on this really lengthy list of things. But what I'd like you to know from this is just that it does amplify psychologic symptoms. So that's the big risk here. And what that's going to be is unpredictable. So it's important to educate patients to not stop cold turkey. Yeah.
Is this only with SSRIs?
So it's with SSRIs. Some of the SNRIs have this too. And I'll point that out on a couple slides here. And again, it depends on your half-life for when you're going to see this come out. Usually a couple days. If somebody's been on even Paxil, which is a short half-life, somebody's been on it for 2 months, it's probably accumulated enough in their system where if they go a day without it, it's not going to have a huge effect. 2 days, yeah, you could start seeing some effects. But Prozac, maybe a couple of weeks before you see anything. And then sertraline and citalopram, those are kind of like 1 day half-life-ish drugs. So somewhere in the middle, I think, 5-7 days off of that, you're probably going to start seeing some of this happen. And of course, it depends on how long they're on it, what the dose was as well, for more severity of symptoms.
Jen,
Yeah.
why would a longer duration of treatment put you at increased risk? Because isn't there that accumulation effect?
There's the accumulation effect, but once it's out, your body's been used to it for a longer period of time. So I think the idea is that you, maybe if you had more receptors upregulated or you're used to a much higher concentration, then you're going to withdraw some. But yeah, it's going to take longer to get to that point. And some would argue that, well, like fluoxetine, you might never get to that point. It might kind of self-taper off and maybe you won't. But I think at some point you're going to get to the feeling that there's nothing in your system and it's going to affect people generally if you don't taper it appropriately. Serotonin syndrome is something that you're going to read about if you read side effects with any serotonergic agent. It's rare, it's deadly, and it likely requires you to take a bunch of different serotonergic drugs. I don't think there's any documented cases of serotonin syndrome from one single serotonergic agent. Could be wrong about that, but I haven't really seen that. And again, I've seen a ton of weird overdoses in my several year career in the ER, and the only time I ever saw anything close to serotonin syndrome was multiple serotonergic agents, like 3 different types of antidepressants that all had some serotonin component. Plus, I think she smoked some like K2 or spice or bath salts or something like that, and who knows what that is. I mean, really, no one really knows exactly what those are. They're changing all the time. So what neurotransmitters that's messing with, we don't really understand very well. So can we blame it on any drug? Probably not. Ultimately, we don't even know what drug she was taking because she left AMA once she recovered in the ICU. So anyway, long story short, this is really rare. I don't know. I've talked to a lot of people. I've talked to a lot of our psych pharmacists. I've talked to psychiatrists, and I just ask them sometimes, like, have you seen this, or what do you think the risk is? Because when you get complicated mental health cases, you end up prescribing multiple serotonergic drugs, and I'll always ask, like, are you concerned about serotonin syndrome? Does the patient have any history of it? And they're always like, no, I've never seen that in my whole career. So I've never gotten the sense that this is a real common thing, and I think, again, it's quite rare. However, it is deadly. And it's a medical emergency. So if it does happen, you get CNS hyperexcitation, usually resulting in seizure-like activity and respiratory failure, muscle rigidity, which causes somebody not to be able to breathe properly. And usually that adds to hypertension and causes hyperthermia too. Those are the 3 big things. So you're looking at some sort of CNS component, hemodynamics, and high temperature. Moral of the story: be careful with using a lot of serotonergic agents, but don't get too bent out of shape about serotonin syndrome happening. Certainly not something I think you need to scare patients with. Like, oh, if you take this one SSRI I just started with you're probably going to have serotonin syndrome and die. No, it's not the right approach. You might want to educate on that that's a rare thing that can happen, but yeah, I probably wouldn't even educate the general patient on a single agent for that. Yeah.
How long do you typically keep patients on them?
On SSRI?
Yeah.
That's a great question. I've got a summary slide where I'm going to talk about that a little bit. Basically, it depends on the case. Some patients you can stop maybe and try off of it. Other patients might be on it for life. It's really case-to-case specific. Okay, moving on to SNRIs, or serotonin norepinephrine inhibitors, or reuptake inhibitors. It's very similar to SSRIs. They just inhibit 2 different reuptake channels in the central nervous system. So working on 2 different neurotransmitters. I'd like to think simply that serotonin is responsible for general mood, maybe not necessarily pleasure, but just sort of things that might make people feel generally happy or motivated about doing things in life. Norepinephrine, I think, more of an energy-related thing, so it might restore some of that lost energy that happens with the depression in some cases. Simple way to look at it, but I like to separate it out. Venlafaxine, or Effexor, is a medication that has mostly serotonergic activity, but in higher doses you get the added norepinephrine in addition to it. So if you start somebody on Effexor, they're probably not going to experience anything different than the standard SSRI for the first dose titrations. If you get them to a higher dose, you might see some of that norepinephrine component come in. This drug has a short half-life, so about discontinuation risk. This has a similar risk to Paxil. I think about venlafaxine and paroxetine, or Paxil, as the 2 highest discontinuation risk medications. So these are ones that, short half-lives, people stop them cold turkey, they're going to feel it. Some people talk about getting an electric shock-like sensation called brain zaps. I don't know. I've never taken these medications, so I don't, and I've never, if I did take them, hopefully I wouldn't have stopped them cold turkey, but I don't have any experience with this, but I don't know exactly what this is, but it does come up a lot, and a lot of patients report this. I don't think this is something you read about on like a side effect profile thing, but it's something that is pretty well documented, that people will say that they get these feelings like they've got like a little shock in their brain. I'm not sure, but not like a seizure, but yeah.
So with Paxil too?
Yes.
Is that only when they're discontinuing them?
Yes, it's a discontinuation syndrome associated thing. Yep. I think what I've read is that the SNRIs are more associated with it, the brain zaps and others, but the SSRIs can cause it as well. There is an extended release formulation. It's the most common way to give venlafaxine, and it is generic. So all the formulations of venlafaxine are generic. It's relatively affordable for anyone. I'd recommend doing the ER formulation for any patient just because it gives you a few extra hours to work with. And if somebody does stop it, it's going to stay in their system a little while longer. More dangerous and overdose than a standard SSRI. Anything with norepinephrine, if you overdose on it. Now, while it's working the central nervous system, we generally don't think about it in the traditional like pressor sense, like it's going to cause blood pressure changes. But if you take a ton of it, it can. And so that's one risk with if you take like a whole bottle of venlafaxine versus a whole bottle of citalopram. Less sexual dysfunction. So SNRIs generally don't have the sexual side effects that SSRIs do. At least they're much lower prevalent. So this is one of the common secondary classes of antidepressants that people switch to if they start an SSRI and they have significant sexual dysfunction. You're pretty much, it's like maybe, let's say, 20% on an SSRI, 3% on an SNRI. It's very rare on these drugs versus the SSRIs. They're generally activating, so if you have somebody who is struggling with sleep to begin with, it might not be a great drug, especially at higher doses. And I gave a little bullet point to its cousin, or enantiomer desvenlafaxine, which is brand name Pristiq. It's an alternative. I'm not exactly sure what the advantage is. I've tried reading about it multiple times, and I can't find any literature that supports why you'd use one over the other. I think, again, with mental health, sometimes you don't really know. When a new drug comes out, you don't necessarily know how it's going to work. You know it's been through some clinical trials and then it's been proven, but a lot of mental health trials are placebo-controlled, which really makes no sense. But that's the way they do them, especially for antipsychotics, which is terrible. But anyway, the point is that somebody studied it at some point, and it's a new drug. So your patients tried everything under the sun. Well, let's try this one and see if it works. That's kind of the strategy. Pristiq is brand name, though, so you would probably have to get a prior authorization to pay for it. Similar mechanism, same mechanism of action, same side effects, same pretty much everything. Again, I can't really find a difference between Pristiq and Effexor. Okay, Cymbalta or duloxetine is a good antidepressant. I put that up there, but people use it for everything else other than depression. So while you can use Cymbalta for depression, certainly, it's approved for that, it was developed for that, and it works for that. You can use it for neuropathic pain, fibromyalgia, and it's pretty much getting indicated and studied in any type of pain syndrome under the sun. So I think this is a good choice for somebody who has maybe chronic pain and a mental health illness. It's kind of got a double benefit there, and I certainly think that it's well studied in both areas. So it's been a popular drug and one of the top selling drugs in the United States for a reason, because it has a lot of cross indications that people use it for. It is contraindicated in patients with hepatic and renal insufficiency, and it's got some metabolic side effects, but overall very well tolerated medication. And this would be similar to Effexor. You could switch somebody, or venlafaxine, you could switch somebody from an SSRI to this and hopefully avoid sexual side effects and maybe be a little bit better tolerated, and slightly different mechanism as well. All right, these drugs are kind of newer, kind of older, and I'm not going to test you on them because they're really rare. I don't know why I gave them a whole slide, but they are sort of like SNRIs. They're milnacipran and levomilnacipran, and both of them actually have fibromyalgia indications, but they were developed as antidepressants. So similar story, but actually they're specifically used for fibromyalgia now. However, I've actually seen them cross back into the mental health arena just because, again, we have patients who have tried other things and let's try this and see if it works type of a strategy. Talk about MAOIs in a second here, so hold on a second there. Okay, other useful antidepressants. Trazodone. Trazodone is brand name Deserel, although it's been generic forever, no one calls it that. Mostly used as a sleep aid, so trazodone's a really common sleep aid. It's non-habit forming, but it is traditionally an antidepressant. It's very anticholinergic, so people wake up dry mouth. Some people report like a hungover feeling after they take trazodone, but widely used as a sleep aid. It does work as an antidepressant, but the dose has to be quite high. And in order to take that much trazodone, you're probably going to be pretty sedated, so a lot of people won't tolerate antidepressant doses. So that's really all I'm going to talk about with this. I don't really care more than that. It does come out with this ER product called Eleptro, which I'm not sure the benefit. It's still going to be sedating whether it's extended release or not. So I don't know why anyone would consider taking trazodone during the day. Bupropion is Wellbutrin, which is a really popular antidepressant. It's got a unique mechanism of action where it focuses mostly on dopamine reuptake inhibition. So now we've got kind of the 3 tiers of mental health-related neurotransmitters: serotonin, norepinephrine, and dopamine, to simplify it. So this drug is useful for a couple of things. So a lot of times, and where it maybe got its original run is, well, it was studied as a standalone antidepressant. Where people found it to be really beneficial is adjunct to SSRIs to improve sexual dysfunction. It works quite well for that, and it can pretty much mitigate that side effect. In addition, it's an antidepressant on its own, so you're adding hopefully a beneficial therapy. It's very well tolerated otherwise. The big thing to remember with toxicity or side effects with bupropion is seizure risk. So especially at higher doses, overdosing on bupropion can be pretty nasty, and it can cause seizures. It lowers seizure threshold, so for epileptic patients, generally not something we're going to try with them. It has a bunch of other indications too. Because it works on dopamine, people try it in various compulsive disorders or addictive disorders. And that should make sense based on how dopamine works in our reward system that we have built into our bodies. So seasonal affective disorders, smoking cessation, gambling addiction, other addictions potentially have all tried dopamine. Probably smoking cessation is the biggest one where it's been studied and well used. And it's got pretty good data in there. We'll talk about that separately in a different lecture. Mirtazapine is Remeron, which is also, like trazodone, commonly used as a sleep aid, but unlike trazodone, people can actually take this at decent doses and be functional during the day. So it's kind of got an odd mechanism. It's still thought to be partially serotonergic, but it also has some alpha-2 antagonism, which is thought to indirectly cause an increase of central nervous system release of serotonin and norepinephrine. So again, we get these drugs and they come out and they're like, oh, this one's new, it's got a different mechanism. It's like, really, is it new if it just works on serotonin in a different way? I mean, that's kind of like reinventing the wheel a little bit, in my opinion. But it does have a slightly different way, and you will see this drug combined with SSRIs, so can be done. It does function actually also as an antagonist of several serotonin receptors. The concept is you have maybe underexpression of serotonin in one part of the brain, overexpression in another. So block part, enhance the other, things shunt to one side potentially. I think that's the idea there. I don't know, I don't design drugs, but that's what I think about anyway. Also, sleep aid uses. This is kind of an interesting point with this drug. It's one of the only ones I can think of that does it. Lower doses tend to be more sedating with mirtazapine than higher doses. And so if you're going to treat it as an antidepressant dose at a higher, more therapeutic dose, you might not actually get that much sedation from it whatsoever. But even so, people are going to take this at night. No sexual dysfunction really to speak of documented with this, and minimal GI disturbances. So see where I'm going with this? Our SSRIs are really common, they work great, and they're solid drugs and a good starting point for a lot of patients. Sexual dysfunction is a huge stumbling block. So here's our alternatives. You have your SNRIs, you have bupropion adjunct, or you could switch completely to bupropion. And now you have mirtazapine as a switch or an adjunct as well. Mirtazapine also stimulates appetite, which can be bad and good, right? So you have a patient who's overweight because they've been overeating when they've been depressed, and they might have some metabolic things going on. Might not be a great choice. You have somebody who's cachectic and lost a ton of weight because they haven't been eating, which you can get both sides of the spectrum with depression. Certainly a useful tool in some patient populations. All right, Trintellix. Vortioxetine is Trintellix, which used to be called Brintellix, but they made them change their name because it sounded too much like the platelet inhibition agent Brilinta or ticagrelor. Interesting fun fact there. Vortioxetine is a really new drug. It's another one of those that, kind of like Viibryd, it came out and they're like, oh, this is new, it's got a different mechanism. Nah, not really. It's a 5-HT or serotonin reuptake inhibitor. Also has some agonism and antagonism in certain areas of the central nervous system. Really nothing new here. It's more of the same, but slightly different enough where patients might respond to it differently, and you never really know. So again, even though this is new, we're still seeing it prescribed pretty often. I'm not surprised to see people on this. And I don't think it's like a drug company thing where people are pushing these new drugs to make money. That's part of it. But I do think that there is a demand for new ideas out there when it comes to depression. We're exploring and still exploring the serotonin concept. It works for a lot of people, but there's a lot of people where it doesn't. And so if we can modify it a little bit or change it altogether, I think that's a good thing. All right, older drugs. TCAs. TCAs are rarely used anymore. If I give you a TCA in the test, basically what I want you to know is that they're essentially SNRIs. They aren't all that much different. They have some other effects too. They're very strongly anticholinergic for the most part. They're very sedating and very deadly again in overdose. So they actually have some class 1 antiarrhythmic potential. And in regular dosing, they don't really affect the heart whatsoever. But if you take a ton of it, or even a small amount actually above dosing, it's got a pretty narrow therapeutic index. Certainly if you take a ton of it, you're going to have cardio effects. And there's no reversal agent. You can't knock it off the receptors. You can't bind it. There's nothing you can do really. And you can treat symptomatic things. You can try and give a bunch of IV fat emulsions to bind it up. That's one of the strategies people have used, but there's really nothing you can do. It's a really nasty overdose. So very much limited its role in modern medicine. However, people like to take them for things like sleep. They're sedating, so small doses for sleep aid. We're talking about sleep as separately, so you can kind of just keep that in the back of your head for now. And then neuropathic pain, just like our other SNRIs, they do have indications for neuropathic pain as well. And we talked about them a little bit with respect to GI and irritable bowel and some other things like that. Yeah.
Sorry, going back a little bit. What is the difference between a 5-HT reuptake inhibitor and an SSRI?
Same thing.
Oh.
Yep. 5-HT is an abbreviation for serotonin.
Oh.
Sorry. Yeah. All right. MAOIs are even more rare, but they're very interesting drugs. We talked about them during PD, and I'm not going to go into a ton of detail on them now, but there are two ones that are pretty much on the market here. And these were kind of the original antidepressants out. And the thing about them is they're actually really effective, and probably more effective than our current drugs. They're very potent, but they come with the nasty side effect of causing hypertensive crisis if you consume too much tyramine, or if you do things like take a bunch of Sudafed when you have a cold. They can cause a lot of issues, and they have the highest risk potentially for serotonin syndrome. This is the one class of drug where I think people still get pretty concerned about serotonin syndrome. And so monoamine oxidase inhibitors, we actually wash people out before we would change them. So what that means is that somebody's on an MAOI and you want to change them to something else, you actually have 2 weeks where they stop and don't take anything. So you don't do any type of cross taper, which is a washout period. Or same thing if you're putting somebody on a TCA. You want to make sure that whatever they've consumed, if it's serotonergic, so SSRI2 MAOI, you do a couple weeks of washout as well. So that's the only drug you actually have to do that for, and that's because there's still a pretty high risk, or concern at least, for serotonin syndrome with these medications. Super rare. I've seen a couple cases of them in my career, and not that I have the longest career in the world, but they just aren't used that much because they aren't safe. And most patients don't get to the point where they would be considered for something like this. So don't worry about those for the exam. I know they're interesting drugs again, and I'm probably spending too much time talking about them for how much you'll actually see them in real life. But I did talk about the tyramine thing, and here's a drawing of how it works and everything, but I won't go into that again. Okay. Non-pharmacologic options, relaxation techniques, exercise, address comorbidities, supplements. How does any of this stuff work? Does it fit in? Some things have been studied. A lot of things have been studied. Relaxation and exercise. Exercise has been shown to be as effective for drugs in mild cases of depression. I kind of think of it like St. John's wort. Both of them pretty effective for really mild cases of depression. I'd say great adjunct for a lot of people. I mean, who couldn't benefit from some exercise unless they're over-exercising for some reason? But pretty much everybody could benefit from a little bit of exercise here and there. So why not recommend it to your patient, especially if it can help their depression? Address comorbidities, anxiety and sleep disturbances. So these things hopefully will resolve as you treat the patient, but you want to make sure that you're following up on them and possibly prescribing other medications if needed. Supplements. Omega-3s have pretty much every mental health patient I see is on an omega-3 supplement. They aren't well studied in depression. There are some little trials that say they could have benefit, but it's really inconclusive. Vitamin D, I think I said this during the supplement lecture, but there's one decent study out there that showed vitamin D plus fluoxetine, patients did better than fluoxetine plus placebo. So there's that. Pretty much all mental health patients, again, on vitamin D. And we talked about St. John's wort already. Light therapy was pioneered for seasonal affective disorder, and sometimes they use it as an adjunct and as an antidepressant as well. You have to have a specific wavelength of light and it sort of has to be facing you for a certain period of day. I think it's a couple hours you're supposed to have it on you a day. And so it's for people generally who are maybe in Minnesota during the winter who don't see the sun all that much. Psychotherapy, and again, highly recommended for pretty much any form of depression or any mental illness, really. All right. Duration and phases of treatment. Short term, usually 6 to 12 weeks, is your ramp up period, and the idea is within 12 weeks you should be able to titrate the person or get the person on what would be considered a therapeutic dose, and at that point you can reevaluate whether you need to change medications, add something on, or stop altogether potentially. If no response during this phase, you consider a treatment failure. If things go well, then you continue for 6 to 12 months to keep symptoms in remission. We'll talk about what we do if there is treatment failure here in a second. Maintenance is defined as just long-term therapy. It's indefinite. And it's for patients at high risk for relapse. So a question about how long do you keep that on? Well, if somebody has had significant mental health issues, if they've had problems with suicide in the past, if they've had long-term trials of medications that haven't worked and they're finally on something that does work, or issues with relapsing off medications, I would say I would be very cautious in stopping an antidepressant in those groups of patients. Okay, so let's talk about how we treat these patients. So there's different kind of guidelines out there, but not really. There's a lot of different ways you can go, and depression is a bit of a scattershot approach. Again, there's not a lot of evidence that says one SSRI is better than the other. Most people would agree that SSRIs are first line. I think all people would probably agree that. But where you go from there gets really confusing. So here's a trial that was sort of a hallmark trial. It's kind of old now, but I think it's still really relevant, actually. It's called the STAR-D, and they looked at almost 3,600 patients with unipolar depression, and they stratified them. So I'm going to show you the diagram here because I think it's easier to talk about this. It looks really confusing, and I'm not going to test you on this, so don't worry about it. But it does give, I think, a frame of reference if you're trying to study and realize, okay, how did they do this in this trial? How do I add things sequentially to patients? So they enrolled over 4,000 people. There were some people that just didn't follow up to the baseline visit, so they excluded them. They put all those people on citalopram. Again, this was when citalopram was the big drug. And then out of all these people, 1,475 went on to follow-up, meaning that they did successful with the citalopram, and they're in remission essentially at that point, which is kind of like our statistic, right? If we think about it, it's maybe a little over a third, so that's pretty good. 766 people exited the trial for whatever reason. I think they got excluded, or they didn't follow up, or they weren't compliant, or whatever. Then the rest of it's where it gets interesting. So then they took people and put them into different groups. So if you didn't respond to citalopram, if there's one drug here, that means they changed you to that. So they changed you to bupropion, or sertraline, or venlafaxine. Or they added bupropion onto your citalopram. Or they added buspirone. We haven't talked about buspirone. It's kind of an anxiolytic drug used mostly in general anxiety. It's kind of a serotonergic agent. It's very similar to an SSRI. Or they did citalopram plus cognitive therapy, or they cut drugs out altogether and did cognitive therapy. And so you can see where people went after these. So they put the cognitive therapy arm in one half. And there aren't a lot of patients here, so the numbers get like, well, how relevant is this? Especially when you get down here, and that one person ended up on venlafaxine plus mirtazapine. So it's interesting that you see these different strategies that they took. And the point is, I'm not trying to talk about, and I'm not going to go into which ones were more effective per se, because I think that they all had some efficacy, and you can see the follow-ups, which ones did well and which ones didn't. But for the most part, it takes a lot of trial and error to get to tranylcypromine. So this is a MAOI inhibitor. 3 people out of all these people, and this is older data too. This is with all the new modern adjuncts we use, they didn't even have that. There's not even an atypical antipsychotic on here, and those are the primary adjuncts we're using a lot in modern depressive treatment, which we'll talk about in a second. So with that in mind, again, this is a little bit old, but I'm just doing it to point out that some of these drugs are still quite rare to see. And again, you have a few more people who ended up on the MAOI here, but again, a lot more people that went through that treatment pathway. So talk about some of the augmentation, some of the ways we can do this, but let's talk about adjunct therapy. So talked about a couple of the different antidepressants, and now we're looking at some of the other things we can do. So first of all, if you start with your SSRIs, your foundational block, what you can add on are your other antidepressants, so things like Wellbutrin. Things that have been also trialed are for people with thyroid hormone issues, liothyronine or Cytomel, so active T3 has been shown to help. But the big ones are other psych drugs that people are using. So that's going to be the most common thing you're going to see in practice now. I don't know whether or not there's a lot of evidence to support it. I think it might be anecdotal and it might be case report or small subset groups, but it's definitely the most popular strategy right now. And we'll talk about those during antipsychotics a little bit here in a second. Yes?
Would you always stay with the SSRI if they're not going to be causing any side effects?
Most likely, yes. If you didn't get any benefit whatsoever, you could maybe stop it. But if you thought there was some improvement, I would keep it. Other useful indications. So we talked about a couple of these things at the beginning, but generalized anxiety disorder, first line, OCD, SSRIs are first line, and again, treated very similar. We'll talk about anxiety a little bit more detail, but that's basically the same thing as what we're talking about here. So summary, mild to moderate depression, SSRI plus I'd say psychotherapy for everyone, or recommended at least. 6 to 12 weeks poor response, you're looking at trying another SSRI, switching to an SNRI or mirtazapine, or adding bupropion. I'd probably go with one of those strategies first. While you can combine mirtazapine and SSRIs in some cases, you generally don't combine an SNRI with an SSRI. I've seen it done occasionally. It's just kind of frowned upon and thought to be too duplicative in nature to be helpful for most patients. 6 to 12 weeks, poor response after that. T3, so Cytomel would be an option, or liothyronine. Mood stabilizers, which are kind of like our anti-epileptic drugs, or are anti-epileptic drugs. So like valproic acid's a really common mood stabilizer. Lamotrigine's used quite a bit in mental health. Carbamazepine. Antipsychotics, there's a number of them that have gotten, again, a lot of traction. You've probably seen them advertised. Drugs like Abilify and Latuda, or aripiprazole and lurasidone are those drugs. And we'll talk about those in the next lecture here. Or switching to a tricyclic antidepressant at that point. Maybe trying one of the older therapies in the hopes that they're probably a little bit more potent and you might get a better response, assuming it's appropriate for your patient. And then another 6 to 12 weeks. If you tried a lot of these things, and you could consider these maybe like, arrows that redirect you back to it. So don't think about this as exclusive. So let's say even here you try another SSRI, it doesn't work. Well, maybe you've tried 2 SSRIs now. Let's try an SNRI, or let's add bupropion. So you can repeat within the same category a little bit to try and get the maximum benefit. And I think the further you go down, the higher risk for side effects, the more, I'd say more toxic the medications are. Antipsychotics, mood stabilizers, and tricyclics, definitely not as well tolerated as your tier 2 drugs, if you want to look at it that way. And assume you get to 6 to 12 weeks, if you're looking at MAOIs, you've gone down a number of roads there, and your patient's kind of at the end of the line. So, and it's not necessarily cut and dry with what you do, but I think this is a good starting block and how to stratify the different options you have for adding things or changing things. And we'll talk about antipsychotics in the next set of slides here and how they fit in a little bit more as well. All right, a couple more slides left. Switching between agents, basically a lot of things you're going to cross taper. The only exceptions are going to be your MAOIs, which are going to be your washout, and SSRI to SSRI. Or sometimes SSRI to SNRI, you can consider not cross-tapering. If it's a really high-dose SSRI, you're going to an SNRI, they'll recommend a cross-taper. But otherwise, the other ones would all be cross-tapers generally. Pregnancy, mild to moderate, psychotherapy, cognitive behavior, antidepressants if the patient has a history of previous use or good response. So if they got postpartum with their previous pregnancy, and they did well on the antidepressant during that one, I'd probably consider doing that again. Light therapy and exercise have been studied positively in pregnancy. Severe, pharmacotherapy is always first line plus you're above non-pharmacologics. And factors to consider, maternal fetal effects, prior response, breastfeeding plans, other medications, drug-drug interactions, family history. There's a lot of things to think about. Basically, a lot of the SSRIs are thought to be generally okay in pregnancy. There's not a lot of data that says that they cause long-term fetal negative effects, and in fact most of the time it's like there might be some data that supports mild or very small percentages of increase. Like I read one study about increased ADD risk with people who took SSRIs during pregnancy, but it was really small number of patients that actually had it when all was said and done. So the question is, does that really matter? Is that clinically significant? Does that outweigh the benefit of having a mother be depressed postpartum substantially? Especially if they have a history of that, and I think probably it doesn't in most cases. Generally speaking, the older drugs have more data, so sertraline and citalopram are preferred. They have the most data behind them. Paroxetine, because of its anticholinergic effects and side effect profile, not generally recommended. Fluoxetine is probably safe, but there's some concern because of its long half-life that it's likely to accumulate, especially in a neonate. It crosses the placenta, and so your neonatal kids don't metabolize drugs very quickly until a couple of months or years into life, and so we want to avoid giving them a ton of drug they can't do anything with. Escitalopram is very commonly used, but it's newer. It lacks data compared to the rest of them. But I've had a number of friends and people I know who've taken Lexapro during pregnancy without any issues. Other options, venlafaxine, bupropion, TCAs, they all actually have pretty good data in pregnancy and are thought to be relatively safe. Most don't have very good evidence as far as like they studied them in pregnant patients. A lot of it's retrospective, like most of our pregnancy data. So most of them fall under category C, which is maybe, maybe not. So it's a risk-benefit scenario. And generally speaking, based on how many millions of people have taken these during pregnancy, I think we're pretty solid that the benefits usually outweigh the risks for most patients. Lactation, very quickly. Basically, we're looking at what gets excreted into milk. Sertraline and paroxetine have the lowest levels, and fluoxetine and citalopram have the highest milk excretions. Depending on breastfeeding, sertraline is usually the preferred drug. So a lot of women who have depression associated with postpartum and plan on breastfeeding, they'll start them on sertraline and do them because sertraline is thought to be very safe during pregnancy, and it's also the safest one for postpartum lactation as well. However, if somebody responds well to one, they usually don't change. So if somebody's been on escitalopram through their pregnancy, it's working well for them. You're not going to recommend switching them to sertraline just because it's less breast milk absorption or breast milk crossover. It's likely still a small amount where it's not going to have an adverse effect on the infant. But if you have the ability to choose, which sometimes does happen, you can pick one. I'd pick sertraline. Discontinuing, we talked about this already. Tapering, usually you're looking at 2 to 4 weeks for most drugs, so decrease the dose slowly and they should be fine. All right, let's take a quick 5-minute break and come back and talk about antipsychotics.